Hello, my name is Andrea Orsey, and it's my privilege today to speak to you about the evidence of Dexrazoxane and other interventions on how we might be able to decrease cardiotoxicity, specifically in our pediatric patients. I have nothing to disclose. So the objectives for today's discussion will be to understand the indications for Dexrazoxane, and they do vary among different organizations across the world. To review the evidence for Dexrazoxane, both the benefits and the risks. To review the evidence for other pharmaceutical interventions which may decrease cardiotoxicity, and to also look at exercise as a non-pharmacological intervention which may also decrease cardiotoxicity. So as Dr. Salazar reviewed, there's many mechanisms, as highlighted by the blue boxes, in which anthracyclines, specifically doxorubicin, can cause cardiotoxicity, and these are some of the mechanisms that we're going to be targeting, focusing on the Dexrazoxane initially. So Dexrazoxane was discovered in Oxford in 1972 by Kurt Hellemann, and it has several potential mechanisms, although the exact way in which it offers cardiotoxicity has not been clearly delineated. It's a cyclic derivative of EDTA, which allows it to easily penetrate the cell membrane. And then it offers intracellular iron chelation through a conversion to a ringed open chelating agent, which then interferes with the iron-mediated free radical generation, which decreases the iron-metal ion complexes, which leads to less superoxide free radicals, which are thought to contribute to the cardiotoxicity. Now, as we heard, anthracyclines are basically topoisomerase poisons, and Dexrazoxane is a weak topoisomerase inhibitor. It depletes the topoisomerase 2 beta, which is in the myocytes, which is how it can offer protection against the myocyte death, at least how it's been studied in vitro. The pharmacokinetics of Dexrazoxane show that after a very rapid distribution, it establishes equilibrium in about 2 to 4 hours. And its distribution is basically the distribution of the body weight water volume. So what are the indications for Dexrazoxane? And we're going to review some of the evidence behind these. So the FDA offers Dexrazoxane. Officially, it's approved for women who have metastatic breast cancer, who have already received 300 milligrams per meter squared of doxorubicin and are expected to need further anthracycline treatment. ISOO similarly approves it for all adults who have received doxorubicin equivalents of greater than 250 milligrams per meter squared and are also expected to need further anthracyclines. ESMO is a little more general in its statement. It recommends appropriate cardioprotectant regimen to be considered and planned for all patients at high risk of cardiotoxicity, but they don't really say what the appropriate cardioprotectant regimen should be. And the EMA has undergone several variations, and we'll go through some of the evidence. But in 2011, they restricted it and basically made Dexrazoxane contraindicated for all pediatric patients. It was allowed for adults who had similarly required doxorubicin of at least 300 milligrams per meter squared and were expected to need more, who had advanced or metastatic breast cancer. Some of the reasons for this were because the efficacy in pediatrics had not been further established, but there did appear to be good evidence for adult patients. And also, there was concerns, as we're going to be looking at further, on secondary malignancy concerns. However, this was recently changed a little less than a year ago, on July 19, 2017, based on new evidence. They changed the contraindication to limit it to only being contraindicated for pediatric patients whose treatment course includes anthracyclines of less than 300 milligrams per meter squared. So if a pediatric patient now requires at least 300 milligrams per meter squared of doxorubicin, they would be permitted to have Dexrazoxane. This is the evidence behind the FDA indication, and basically it shows this is in women who have metastatic breast cancer, that there is a hazard ratio of 13. So we have a 13 times greater likelihood of having congestive heart failure if you do not receive Dexrazoxane and receive anthracyclines of at least 300 milligrams per meter squared. So there was a Prior to the Children's Oncology Group, one of the predecessors had a clinical trial. This group has now become part of the Children's Oncology Group, and it was the P9404 trial. And it was a randomized clinical trial of 537 children and adolescents who had T-cell ALL lymphoblastic non-Hodgkin's lymphoma. And they evaluated the oncologic efficacy, cardioprotective efficacy, and safety in a randomized clinical trial of Dexrazoxane. And patients basically had echocardiograms every 3 years. And what they found is that there was no difference in the survival, but a significant change in the cardio benefits. And this is a similar slide to what Dr. Salazar demonstrated, demonstrating that there's biomarkers also supporting that Dexrazoxane can be cardioprotective. There was a Cochrane review, which included almost 1,200 patients. And this is adult patients, but basically it demonstrated a protective ratio where 80% of patients received cardio benefits when they received Dexrazoxane and Anthracyclines. The children's group in Toronto at Sick Kids has done a wonderful meta-analysis reviewing the pediatric patients, and this was published in 2016. And they reviewed a total of 5 randomized clinical trials, which included over 1,200 patients, as well as, sorry, my screen doesn't match this one now either, but they also included non-randomized clinical trials, which had 3,400 patients. And what they found is that there was a significant benefit in the non-randomized clinical trials, but it was for the clinical toxicity, and how they defined clinical toxicity was basically evidence of congestive heart failure, being prescribed medications for congestive heart failure, requiring a heart transplant, or a cardiac-related death. So there wasn't quite enough power, and you can see that in the top group, there were only 3 total cardiac events in the randomized clinical trials of 1,200 patients, so that's why they couldn't demonstrate the clinical cardiotoxicity among those patients, but there were more events that occurred in the non-randomized clinical trial, and they were able to demonstrate statistical significance. When they combined it with the subclinical cardiotoxicity, so subclinical cardiotoxicity is defined as having asymptomatic echocardiogram findings, so a decrease in shortening fraction or ejection fraction or a significant decrease in your cardiac function. When they combined both the clinical and the subclinical, there were more events in both the randomized clinical trials and the non-randomized clinical trials, and both demonstrated statistical significant benefits of Dexrazoxane. Next slide, please. Oh, now it's not... Okay, here we go. So there was also a systematic review of solid tumors, and this included 4,782 patients among 22 studies that were performed after 2000, and they primarily focused on osteosarcoma, Wilms tumor, and neuroblastoma patients. And what we can see here is that with cumulative anthracycline dose, there is a linear survival increase and an exponential increase in cardiotoxicity. But the location of where this exponential increase changes. So in patients who received Dexrazoxane, they were able to tolerate up to 431.8 milligrams per meter squared of doxorubicin before they got the exponential increase. And in patients who did not receive Dexrazoxane, they could only get up to 268.2 milligrams per meter squared before they had the exponential increase in their cardiotoxicity. They also noted that although the Dexrazoxane decreased the rates of cardiotoxicity, it did not protect against the late cardiotoxicity effects. Basically, there was a doubling between 5 years and 20 years off therapy. Now, the patients who received Dexrazoxane still had a lower rate because they started at a lower rate to have the doubling, but the doubling still occurred regardless of whether they received Dexrazoxane or not. So, given the benefits of Dexrazoxane, what are the possible risks? So one that has received a lot of attention that we're going to explore is the risk of a second malignant neoplasm. There's also been concerns about increased mortality, impairing the chemotherapy efficacy, infection, and cytopenias. So there was a report of increased incidence of AML and MDS in a study performed with Hodgkin's lymphoma in patients who received Dexrazoxane. It is important to note that in the study, it was not powered to look for secondary malignant neoplasms, but they did note that there was a change that was reported. And this was part of what led to the change in the recommendations from the EMA in 2011. There was thought that this could be because of possible synergistic effect with the etoposide on the DNA repair, but it was hypothesized. So there was a study performed by Eric Chow where he basically reviewed all the Children's Oncology Group-related studies who randomly assigned Dexrazoxane to patients. And there were 3 studies in which this occurred, and it encompassed over 1,200 patients, including the original patients from the original study who were followed over a longer time period. And the initial borderline risk was really not found to occur on follow-up. And you can see from these graphs that there was no difference in patients who did or did not receive Dexrazoxane in their overall survival, event-free survival, death from secondary cancer, or death from other toxicity. The Pediatric Health Information Systems is an organization at the United States that basically includes a large amount of patient data in a business alliance. And there was a group out of Philadelphia that has published some information that demonstrates both significant variation in how Dexrazoxane is given. So the first 2 graphs, you can see that over the years there's been a significant variation in AML and ALL patients who are prescribed Dexrazoxane, as well as geographical variation within the United States. And it varies a lot in different institutions and their policies. But more importantly, for this purpose of this discussion, between 1999 and 2011, there was over 15,000 patients who received anthracyclines in this large database, which encompasses over 50 hospitals. And they noticed that there was a secondary AML rate of 0.21%, or 3 out of the 1,400 patients who received Dexrazoxane. And it was 0.55% for patients in the unexposed to Dexrazoxane group. So that was 77 patients among 14,000 patients. So that also demonstrated that there was no statistical significance of increased secondary malignant neoplasms. And in fact, in that group, it was more likely if you did not receive Dexrazoxane, but it was not statistically significant. So it really didn't hold weight in a large volume of patients. Again, going to the review of multiple analyses and the retrospective, the meta-analysis that was performed out of sick kids, they also evaluated this, and they found that there was statistically not significant increase in the secondary malignant neoplasms, both in the randomized clinical trials and the not randomized clinical trials, and looking at a large volume of patients as well. There was also a nationwide Korean study which included 1,453 patients across 15 hospitals. And what they found is that the Dexrazoxane, again, improved cardiac event-free survival rates, and the secondary malignant neoplasms was not related to Dexrazoxane in multivariate analysis. There's concerns about the survival rate, but again, looking at the large meta-analysis done out of sick kids, there was not statistical significance in the event-free survival rates. Among a group of AML patients at a single institution, this was in Wisconsin in the United States, this institution had adopted given Dexrazoxane prior to anthracyclines in 2011, and they found that there was no difference in the event rate or the overall survival and improved cardiac function in their population as well. There was a Cochrane meta-analysis of the different randomized clinical trials in which Dexrazoxane had been randomly assigned, and they also found that their progression-free survival rate was not different whether or not patients received Dexrazoxane. And also among women who had breast cancer, the response rates to their chemotherapy was not different based on whether or not they received Dexrazoxane. So it did not appear to have anti-tumor effects or be affecting the chemotherapy efficacy. Cytopenias was also commented in the rationale for the EMA recommendation, and I think this is a very complicated issue because, as we know, children who receive chemotherapy often will experience cytopenias as a result of their chemotherapy, and their hematological events very well could have been related to their chemotherapy. There was one randomized clinical trial that done a grade 3 or 4 hematological toxicity was identical in two groups, whether or not they received Dexrazoxane. So as most people would do, routine hematological testing and blood product support is recommended in all patients, whether or not they received Dexrazoxane. There are some liposomal anthracyclines that are being investigated that might decrease the blood concentration of anthracycline and concentrate it in the tumor cells, and this has been proposed to potentially decrease cardiotoxicity 5 times with the same efficacy. There is currently a children's oncology group study evaluating such an agent called CPX351 in AML patients with refractory disease. So what other agents can be potentially useful in helping with cardiotoxicity? So beta blockers have been evaluated, and this is demonstrating that beta blockers in a group of 50 patients, 25 in each in a randomized clinical trial, did demonstrate that they were able to preserve cardiac function. There is currently an open children's oncology group called PREVENT-HF, which stands for Pharmacological Reversal of Ventricular Remodeling in Childhood Cancer Survivors at Risk for Heart Failure, but it's a very cute name. It's a phase 2b randomized clinical trial, and it's basically looking at carvedilol compared to placebo in childhood cancer survivors who were exposed to at least 250 milligrams per meter squared of doxorubicin and did not receive Dexrazoxane.
Must wrap up just now.
And there's also another beta blocker called Nivola, which also has demonstrated preservation of cardiac function. Statins have been investigated because they have some preclinical data demonstrating decreased oxidative stress, decreased pro-inflammatory cytokines, caspase-mediated apoptosis, and they show some promise, but we need further evidence and further research to be able to be done, and this is a further study evaluating statins and the preservation of cardiac function. ACE inhibitors have also been looked at, and similarly, there's promise, but we need further studies. These are relatively low numbers of patients involved, and combining ACE inhibitors with a beta blocker also offers another potential mechanism that may help. And then Lcarnitine is a substrate for the myocytes, and it's been proposed that potentially replenishing this may support the cardiac function and help mitigate some of the cardiotoxicity effects as well. But similarly, we need larger randomized clinical trials to really evaluate if this is beneficial. Exercise, we know that our patients are more sedentary than patients who have not had cancer, and very few of them are meeting the CDC guidelines. This was an exercise study performed on mice who did a progressive exercise treadmill test, and it demonstrated that they had preservation of their heart function if they were regularly getting aerobic exercise on the treadmill, which was basically 3 hours a day. There's very limited information out there on pediatric cancer patients and exercise, especially compared to adults. We do know from the limited information that it appears safe and feasible, and we really have very limited adverse events that are described. And it appears to potentially offer benefits in decreased fatigue, increased muscle strength, and increased quality of life. And there's been some small studies. This particular study had 21 patients, but it did demonstrate improved cardiac function, which really speaks to the benefits of exercise in preserving cardiac function. So we potentially need some better, more innovative, tailored physical activity programs to help our patients, and potentially including families may be beneficial as well. The Children's Oncology Group does offer guidelines, but they're very general, saying aerobic exercise is safe and should be encouraged. And there are some limited guidelines available, but there's very limited evidence behind some of these guidelines that have been developed. And I want to highlight that there's a group out of Alberta that has developed a pediatric oncology exercise manual to really inspire and promote the healthy, active lifestyle that we hope our patients will be able to enjoy. And as Dr. Salazar mentioned, at our institution, we are currently developing guidelines, and we are looking at major risk categorizations and minor risk categorizations and trying to really look at a retrospective database and bringing it prospectively to categorize the risk groups of our patients, with the goal being that when you have a new patient that comes in, you might be able to determine if they're at low risk, moderate risk, or high risk of developing cardiotoxicity and eventually implement both preventative, secondary, and tertiary interventions as early as possible. So in conclusion, the evidence really speaks to Dexrazoxane being an effective cardioprotectant in adults and children. There's really not any evidence demonstrating that it's associated with increased secondary pediatric primary neoplasms. It's not associated with excess mortality. It does not impair anti-tumor efficacy of anthracyclines, but we do need more prospective long-term studies. It seems to be a very similar trend in pediatrics. Also, we need further research for Lcarnitine statins, neurohormonal antagonists, which is the ACE inhibitors. Exercise is safe and feasible, but we need randomized clinical trials to figure out how to best implement exercise in the effect size, optimal exercise format, and durability. Don't know if we want to take questions now or wait till the end.
Yeah, I think thank you very much for your lovely talk.